And I know because the minister was at your hospital, the matter had come up, minister had given some directives. Why did you see the need to put out such a statement?
Okay. So it's been hectic in Korle-Bu for quite a while now. I mean, Korle-Bu is the foremost institution in the country, and we receive a lot of patients. So the emergency is almost always choked. And we have a problem with our referral system. We saw the need to issue this statement because the first step in solving this problem is to recognize the problem itself. If we paper cracks, we wouldn't be able to solve any problem because we wouldn't even know the problem. So in view of that, we thought whatever happened on the day the minister visit wasn't the real state because we work here and we see patients at the emergency. I mean, executives of CODA and CODA members are the doctors who work in Korle-Bu who see patients at the emergency. So we are aware of the state of the emergency. So we thought we should make it clear so everyone knows that this is the real situation at hand and we know how to solve the problems we have.
Give us an idea of what you see as the problem. First, because you're talking about our referral system, which ultimately lands most cases at the hospital. And then you're also talking about the situation there at Korle-Bu itself. Paint us a picture.
So basically, I mean, there are various levels of healthcare. We have the primary, we have the secondary, there's the tertiary institutions like Korle-Bu, Komfa, Noche, and now we have quaternary hospitals as well, which Korle-Bu is trying to do, and UGMC is supposed to be a quaternary hospital, but not readily accessible to normal Ghanaians, unfortunately. So not every illness is supposed to be referred to these tertiary hospitals. And in advanced countries, before any referral is done, the hospital referring the patient would have assessed the patient, stabilized the patient as best as they can, called the hospital they want to refer to, discussed the case with them, and the hospital would have given a response to bring the patient. So for that, before the patient is in, a bed is already available for the patient. Any medication, any other thing being used for the patient will be available by the time the patient arrives. But it's the case that in Korle-Bu, especially after the directive was issued by the hospital and the minister, patients are just moved to the emergency without prior notice. So you would be at the emergency and about 10, 20 hospitals just move patients to the emergency, and you see ambulances lined up in front of the emergency.
Nobody calls you. Nobody calls you ahead to tell you, expect this patient. This is what is wrong with them, and you will know, you have no prior knowledge of what you're going to do.
Even on a normal day, that happens. Even before this directive, that happens. There are times that other hospitals would call, discuss the cases. Either they are told, okay, we are ready, bring the patients, or okay, there's no bed at the moment. But if this was wrong with the patients, do this, do that. Maybe try this other hospital and maybe call us back in the next 2 hours, 3 hours, and let's see whether we've created any space for you. But after this directive, I think other hospitals thought, okay, right now no patients will be turned back, so let's just take our patients to Korle-Bu. Then let them deal with their issues over there. So emergency physicians became overwhelmed and patient management was suboptimal because patients were on the floor, patients were in chairs, and those are not optimal conditions under which patients should be managed.
I see. That's interesting. So prior to this directive, you had that kind of interactions before the patients are sent?
Yes. So that's supposed to happen. As I mentioned earlier, even before the directive, patients were still referred without being called.
Okay.
But the fact still remains that after that directive, the number of instances that happened just increased exponentially.
I wonder why. Okay, so you say because of that, you've had situations where you have to care for patients in chairs
Yes,
on the
people
floor.
are nursed in chairs. People were on the floor last week, unfortunately.
I see, because I spoke to the CEO of the hospital who says his attention has not been brought to a situation where a patient had to be nursed on the floor.
And that's quite unfortunate. But I can confirm to you that patients were nursed on the floor.
How do you do that? And when you are forced to do that, nursing patients in chairs on the floor, are there any risks involved?
Yes. So, first, to the patients, that's not the best place to manage a patient. Because a patient should be on a bed for the patient to have a thorough assessment when the patient comes in. A patient on the floor definitely won't have the kind of assessments a patient on a bed on a monitor would have at the emergency. That's one. To the doctor who needs to bend down to assess the patients, the doctor who needs to bend down to do procedures on these patients would also be at risk. One is an occupational hazard to the doctor. In the future, this doctor would need to see a neurosurgeon for a back problem or another. Now, to the doctor as well, if anything happens to this patient, you'll be at a legal risk because the law doesn't recognize good intention. A judge won't sit in his seat and say that, oh, you just wanted to help the patient, and because it was suboptimal, something bad happened. No, that won't happen. You will be held liable if anything bad happens because you managed this patient in a suboptimal position.
And I wanted to explore that point a bit more. The one about the legal implications. When these things happen, and unfortunately, the unexpected happens, and you're sued, you said, is it the doctor that will be held liable or the hospital?
So if something happens in the hospital, they sue the hospital. They sue if it's in the department head of department, the consultant in charge, and the doctor himself. But it's only the doctor whose license is at risk. The hospital might be fined. The hospital might pay the fine, or government to pay the fine on behalf of the hospital. But it's only the doctor whose license is at risk.
I see. Very interesting. So now, exactly what do you want to improve? What do you want done about the situation?
So we think this problem is not a Korle-Bu problem. Bulk of this problem comes from outside Korle-Bu. That's resourcing the district hospitals, the regional hospitals to handle most of these cases. Because the truth is, more than 50% of the cases that are referred to Korle-Bu can be handled outside Korle-Bu if they are well-staffed, well-trained, and well-resourced. So that Korle-Bu can handle those cases that really can't be handled outside Korle-Bu. Then those cases are transferred to Korle-Bu and duly managed over here. So we think we should assess the problem holistically. Then we solve it as it should, and not be just managing a crisis that happens. Let's bring more beds, let's create more space in Korle-Bu, and manage extra patients with the same number of staff, with the same resources still available in the hospital.
So your proposal is a holistic view of the entire
Yes.
system, not only Korle-Bu.
No, please, not only Korle-Bu, because bulk of the problem is not in Korle-Bu.
Oh, I see. So what needs to be improved at those hospitals to reduce the pressure on you?
So these hospitals need to be well-resourced. They have to be well-staffed. And they can handle most of the cases that are referred here. Because it's very disheartening if you see a patient come from a hospital, a district hospital, probably with some complications of diabetes or a high blood sugar. This should be managed at the periphery. I mean, you shouldn't see a patient at the emergency of Korle-Bu Teaching Hospital and say, oh, the patient sugar was high, so we refer to Korle-Bu.
Really?
Yes.
So, how constantly do you see such cases? Cases that you believe should be handled at the district hospitals, but end up there?
It's a daily occurrence. It's a daily occurrence. It happens always. And I think the best people to discuss that will be the emergency physicians.
Oh, I see. So, deal with the periphery so that it doesn't come to the center, which always, most of the time, is Korle-Bu. But can something also be done about Korle-Bu itself?
Oh, definitely. I mean, once there are plans to expand the emergency capacity at the hospital, that's welcome. But that also should come with increasing the staff numbers, increasing the resources available to the staff to use.
What about ensuring that the usual coordination that happens between you and the hospital is prioritized? Because you said there were many hospitals who typically would call you, have a conversation with you before sending the patient over. Going back to that regime, how significantly will it help?
Oh, yes, that's one of the solutions to this problem. So having a robust referral system where cases are discussed with the referral hospitals before they are referred to the teaching hospital. I mean, it shouldn't be just Korle-Bu, because there will be district hospitals who also want to refer to regional hospitals. All these should be done. So it's not just a Korle-Bu problem.
And I don't have to leave you to work. So let me conclude by asking you a question, because I know perhaps you speak for the doctors at Korle-Bu, for example. You've heard these discussions over and over again. No bed syndrome. The health professional is not being professional. It's not doing their work well, among others. How does this sound to you? Is there something that we are missing in this debate? Because I'm sure it's come up a couple of times. You've heard it a couple of times. What are your own views about the discussion, how we have it? And do you think we communicate an understanding of the problem?
So it's very difficult handling healthcare problems. You see, at the end of the day, the healthcare worker always bears the brunt of whatever problem happens in Korle-Bu. You understand? And in the hospital in general, because anyone who comes to the hospital is ill. The patient himself or herself is probably at his or her wit's end. Relatives are disturbed. Everyone is emotional. And I agree that sometimes there's a problem with attitude of healthcare workers. But if the problems are not solved, the healthcare worker always bears the brunt. And it's always, oh, they didn't do their work well. This one is because the doctor did that. It's because the nurse didn't smile and the nurse didn't do her work well. But at the end of the day, if a doctor is overworked, if a nurse is overworked, there's always a chance of something bad happening.